you're streaming.
All right, welcome everybody to one of our favorite sim sessions on a very important topic, cardiac surgery. If we have everybody online, you can hear us okay? All right. So I will need a volunteer for our first case.
Gotta be a first-year fellow.
Very good. Okay, so Tom, you have a patient, he's a 51-year-old male. He just underwent a CABG ×4 AVR MVR. It's quite a surgery. He is doing well post-operatively. He just got extubated, and they were turning him, and all of a sudden he went unresponsive. And Jason, can you pull up the slides? This is what you see on the monitor.
Short, so I'm going to put that.
Okay. And he has a pacer?
He has epicardial wires, correct. How do you know?
He has a pacer box connected to him with the epicardial wire here.
Point to the guys at home.
Yeah.
And are those V or A wires?
I don't know.
Okay. Anybody know?
So it's both. It's orange and white.
Orange and white, okay.
Yeah.
So the color, there may be color coordination here and where you work, but it doesn't necessarily mean anything. It may be different colors, right? What's the other convention for how you know which one's A and which one's B wires?
The way it's hooked to the box.
So it could be where okay, very good. So maybe they hooked it up correctly and one's going to A, one goes to B.
Yeah.
But if it's on the left side of the sternum, typically it's B wires.
Okay.
On the right side of the sternum, it's typically A wires. Okay, so what's a rhythm that you see?
Asystole.
Asystole, okay. So patient's unresponsive.
Yeah.
So what are you going to do?
Try to pace.
Try to pace?
Yeah.
Okay. Why is that? Like you wouldn't do that with anybody else.
The first part of the algorithm in the post-cardiac arrest.
Yeah, so good. So there's a different algorithm for post-cardiac arrest patients. I guess I'm supposed to stand in this box there. There's a different algorithm for post-cardiac arrest patients, and we'll go into that. So, okay, so you want to pace the patient, right?
Yeah.
So you come over here, right? So simple things first, right? You're going to check that it's connected.
Yeah.
Okay, so it didn't get disconnected.
Right.
Make sure that the V wires are actually going to the V, right? They're connected at their points there. Okay. Happy with that?
Yeah.
All right. Pacer is on?
Yeah.
Okay. Let's say it was already on, right? Let's say it's already on and you're seeing that, you're seeing asystole, you're not seeing any rhythm. Maybe you're seeing a pacer spike, maybe you're not. What would you push on this box? Like how would you adjust it to try to get captured?
Either turn up the output or just put it into emergency mode.
Yeah. So exactly. So what happens with these leads over time, and we're talking about medium stuff, but over time, these leads tend to get essentially corrosion on them, and so they it's harder and harder for them to get captured. And so they're temporary wires, right?
Yeah.
So one thing you can do is go up on your milliamps. But what's the easiest way, and the way you should do in an emergency, is hit this button. Yeah. So, Jason, can you see that?
Yeah, if you take it off and you want to point it out.
Yeah.
Can you get it off?
Sure. So what you're pushing is which button? So DOO, right? So what does that mean?
It just means you're basically pacing, and you're not like looking for any intrinsic activity.
Yeah, so you're asynchronously pacing. So it's going to asynchronously pace both V and A wires if they're hooked up, right?
Yeah.
Do you care if like it only has V wires and there's something in here or not?
No.
No, you don't care, right? Just whatever's plugged in.
Yeah.
It's fine. All right, so you hit DOO, right?
Yep.
Okay, so what did it do?
Increase the output for the A and B.
Okay.
Milliamps. Okay.
Okay, so increase it, max out the output for the A and the B, right? So it went to milliamps 20 on A, 25 on B. It asynchronously pacing, so it doesn't care what the rhythm does, it's going to keep pacing. Okay, so that's like your best chance at pacing this patient. Okay, so very good. So you pace them, they wake up. Okay, so So good. So one thing about the cardiac surgery patients, right, is they come out with epicardial wires. And so do you know, like, what does that mean, that they're epicardial wires?
Like just pace, like transcute through the skin into the epicardium?
Yeah, so they actually, like, they sew them into the epicardium, right? So you pull up the slide, Jason. So just, oh, you can't really see that. I'll just draw on here. So what do you guys know about the different modes of pacers? What are the letters? What are the acronyms for pacing modes? Anybody?
The first letter refers to the chambers sensed. The second letter refers to the chambers paced.
Okay, close. So it's PSR. Okay. So pace, sense, response. Okay. So pacer. So what we typically use, a common mode that we use in emergency pacing, right? We're putting in like a transvenous pacer is VVI. What does that mean? We're pacing the ventricle. We're sensing whether the native ventricle is beating, and if the native ventricle is beating, then we're going to inhibit the pacer. Okay. So we're going to inhibit this pacer. So if the patient's native beat is going at 100 beats per minute, and our pacer's set to go at 80, then nothing's going to happen. As soon as we push this button, it's going to pace independently of that 100 beats per minute. Make sense? All right. So the other common one we have is DDD. This is essentially, even though the letters seem totally different, it's the same as VVI, but using both, if you have both A and B, right? So dual, you're pacing both the A or atrium and ventricle if need be, or one or the other if based on the response. You're sensing both the atrium and the ventricle, and then you're going to inhibit either the atrium or the ventricle or both, depending on what the signals are coming from the patient's native beat. Okay? And then if you want to go to, I'll show you this on the slide. So what does the sensitivity mean? So we can set right? We can set the energy, we can set the current, we can set the milliamps. We can also set the millivolts, the sensitivity. Anybody want to give a stab at what that means?
Minimum threshold required to perform the action.
Yeah, so it's I think it's a confusing term and one that to think about conceptually for a little bit, but essentially it's setting the bar, so the sensitivity is setting the bar or the fence with which the patient's native beat has to go above in order for the pacer box to say, hey, they had a native QRS complex, I don't need to pace them now. Okay? So think of it rather than, like, we often think of the word sensitivity and it's like, oh, the higher the number, the more sensitive. It's kind of the opposite. It's the opposite, okay? So if you pick a sensitivity of, let's say, 2 millivolts versus 0.2 millivolts, right? The patient's native QRS complex or a P wave for the atrium, right? It has to get above. So if it's, let's say this is the native QRS, it's well above 0.2, right? So it's not, the pacer box is not going to fire because it's above that sensitivity setting of 0.2. Yet if you set the sensitivity at 2 millivolts, it's going to keep pacing because it can't see that. It's behind the fence. Okay? So for what it's worth, sensitivity. All right. Okay, so very good. So you saved, and then if you want to go to the next slide. Unfortunately, I can't really see that very well. So there's two kinds of pacer leads that they use. So there's unipolar and bipolar. And what does that mean? And what is it? What's the clinical relevance of that to us? So bipolar leads, right? They have 2 areas on a single sutured wire that will have a negative pole and a positive pole. Okay, so if you had the patients, if you think of it here, right? So you have negative and a positive. They're both on the same wire. Okay, and then when they come out of the skin, it's going to split off, and then you can attach them here. If you have unipolar leads, you're not going to have you're essentially only going to have one, and then on the skin, you're going to have a ground. Okay, so often this would be like a needle or some sort of other ground in the patient's skin that's then connected to the pacer box. Okay, so let's say you have so Tom, let's say you have a patient now that you didn't lose. Let's say they're being paced. They have underneath the pace rhythm of 80. They have a native rhythm that's a complete heart block with a escape a rhythm in the 30s. Okay? And with that, they become hypotensive and symptomatic. So this patient now they're losing capture and they're very hypotensive. So how are you going to troubleshoot? So you already pushed the DOO. You're not getting capture.
Okay.
So what else can you do?
You can like check to make sure the leads are in place, like just troubleshoot the.
Okay, so you're troubleshooting, right? You're running your circuit, right? So it's plugged in, it's on. You're running here. These are the connections are in.
Right.
Okay. Good. All right, they're all in.
I guess you can transvenously pace them if they.
Okay, so you're transvenously pacing. As you transvenously pace, you lose the. They go into asystole.
Yeah.
So you're getting set up to do that, but they're in asystole right now.
Switch to polarity.
Just polarity. Okay. So how do you do that?
Physically switch them.
Show the folks at home. Okay, so what he's doing is he's switching the negative and the positive connections here. So he's switching them, and it sounds like it wouldn't do anything, right? But it actually sometimes just helps you to get capture again. So just literally switching them out right there.
How does that work to get capture?
Why?
Yeah, why?
I'll give you a good answer for that.
Sometimes it just
Unplugging
works.
and plugging back
Yeah.
in.
Yeah.
It's like anybody old enough to have a Nintendo, and you like take it out and you blow in the cartridge. We do all that to try to get these things to work again. Yeah.
Okay, it didn't work.
No. Oh god. Still asystole.
So just transcutaneous series.
Okay, so you tried transcutaneous, it's not working.
You can always try to reground them too.
Reground, how are you going to do that?
So usually, sometimes they'll keep like another 18 gauge around there. You can you stick it through the skin, and then you can put that into there.
Yeah, so let me grab a needle. Gets in my little.
Because I had this hair on my first week on nights. That's not fun.
So again, just kind of running that algorithm,
Grab that
hit
cartridge
the O
or
shit
needle.
button, still not getting good capture, switch polarity, still not getting good capture, reestablish the ground, still not getting good capture, ask for expert opinion.
I did this all with Dr. Brett.
So for some reason we don't have any gauges right now, but we will use a smaller one. So, all right. So Tom, you want to do it?
So I do this.
So this is an atrial wire. I just
Yeah.
put this in for demonstration
Yeah.
that that's there. We're dealing with these V wires here.
Yeah.
So we said that these are, so we're for teaching purposes, this is a single bipolar wire,
Okay.
right? So it splits and then they're connecting here.
Yeah.
Okay, so what we're gonna do is actually just put it through the skin.
Okay.
Yep, just
Get
in and
a
out.
good and get a good
Put it in
chunk
and
of
out.
skin.
Yep.
I think it's
Big
really
chunk.
important, right?
You guys
And
can come up here.
don't be shy because
So we connect one of the wires to the.
Yeah, so just like it doesn't really matter which one you pick, right? Because we just switched the polarity.
Yeah.
So so take out one of them, okay?
You have to press it down.
push the there.
Strong. Still messing up. You wrap this around or?
No, all you do, it's simple. All you do is put the needle into here.
Oh, okay.
Now, some of the nurses may hand you a set of alligator clips because that's the way they're used to seeing it. So I think this is Dr. Noel's ingenious way of hooking up, directly into the connector, or you can put another needle in there and then connect 2 alligator clips to each to complete the circuit. Now, just make sure you get a big enough bite of the skin, because it matters. And also, these patients tend to be post-op day 2 when their pacers fail on you sometimes, so they're going to be awake. Don't be a chicken, because it's life, death, or a needle pinch. So get a good bite.
So it didn't work. Well, what did you just do the step before this?
Took this out of there.
Oh, before that.
Switch polarity. Yeah.
Oh yeah, switch it again.
Switch again? With the needle?
Yeah.
Okay, I can do that.
All right, he wakes up. Space at a rate of 80. Good job. Saved
What
it.
did you do?
All right,
Switching is what I learned.
So just kind of to summarize, like what we did, Tom. Right. So we had a patient who lost capture, and so like our first move, if they're in asystole, is to try to regain capture. And we'll go into a cardiac arrest algorithm, but essentially we don't want to. We're going to try to troubleshoot that for up to 1 minute. So this is like very quickly. We're like going in. Pacer box on, is it connected? Are the wires connected? Are they dislodged? And then the second step is we're gonna then we push our emergency button, right? Activate DOO, maxes out the milliamps, and it puts a rate at 80. You can go up if you need to, but essentially if you're gonna get captured, you should be there. If that doesn't work, next step we did was we reversed the polarity of the leads, and then the last step is we put a new ground in. Okay, so take an 18 gauge needle, whatever needle you have available, do that. If that didn't work, again, reverse the polarity, see if that helps. Beyond that, and if they're in arrest, start CPR, try to transcutaneously pace while you're preparing for transvenous pacer and things like that.
Yeah, like, are you, like, you're getting the pads on as soon as, like, this starts?
Oh, yeah.
And, like, what's your threshold for transcutaneous pacing? I feel like...
I mean, really minimal, right? So if they're already on, you can try it. It just may not work, just with everything that's happening.
Yeah, especially, fresh post-op heart, chest tubes in place, a little bit of air in the mediastinum. You might not get great capture transcutaneously pacing a patient. So the nurses know what to do. You guide them to get, your backup support with transcutaneous pacing while you focus on your algorithm. And that's why I think, working this out in your mind over and over and over again, you'll be able to do this without even thinking, and then be able to manage the room, because someone's going to want to start chest compressions right away, and your job is to try to get through this without having to, mess with their sternum that's not in continuity anymore. So, great. Give me more.
I have a question.
Yeah.
So, the ground, are you grounded on the unipolar?
So, good question.
doing-
So unipolar wires will come out with a ground.
Mhm.
If it's a bipolar system, you'll come out with 2 wires hooked up to the pacer that are out of the skin. But when you ground it, you're converting a bipolar to a unipolar system.
Okay, gotcha.
That's what you're doing.
So Dr. Noel, what's your next step? You make this work at 2 a.m. Do you then just flow to transvenous, not trusting this, or do you?
That's what I would do.
Okay.
I would do that, and so because this is really a temporary thing, right? These are all temporary things. The patient's going to need a more secure way of facing that patient. So yeah, that's what I would do.
Any situations where you think that would be difficult? So I mean, they all have cortices in place, floating a TVP is a non-issue. If they're a mechanical tricuspid or even a bioprosthetic tricuspid, anticipate some issues with floating. So that's where you really want to get your surgeon involved and your, an EP in case they do have to come in and place an emergent pacer, permanent pacemaker. The tricuspids are impossible to flow through when they're mechanical. So just anticipate that being an issue for you. That would be the one scenario where TVP has been tricky. And I remember we had one patient that we actually had her like laying on her side, had a new ground, laying on her side, and telling her not to take deep breaths to just maintain capture until the morning. when she could get her I'm gonna have to cut that out until she was able to get her permanent pacer. So
Would you try going then?
again, it's like you can't wire it across the tricuspid, so it's tricky. Sometimes you can just bury it, and again, like with these, you can bury it, and depending on how bad the conduction delay is, if you bury it in the atrium and jack up the milliamps, sometimes you can get conduction. So you do what you can.
Yeah, and the key with all this, and we'll say it again for your next case, is like don't overthink your normal algorithms, right? So your instinct and what you've been taught for all these patients is to transcutaneously pace. It's not wrong. You can do that right away. It's just these are the next level things that you can do to fix the problem, where the transcutaneous pacing, as we know, is not perfect and may be less successful in these patients than other ones. The difference that Tom pointed out, though, is that unlike ACLS, for any patient where we would not typically try to pace, because it complicates the algorithm, unlikely to work, et cetera, these patients, they have reasons where they lose conduction completely, and so restoring conduction may bring back a perfectly fine perfusing rhythm very quickly without disrupting your surgical site in the median post-op period. Cool. All right, so let's say you're up post-op day 2 on this patient, and you want to check what the underlying rhythm is. How are you going to do that?
Just turn down the voltage.
Okay, you turn down the voltage, you lose capture, you never get it back.
There's a pause button.
Okay, pause it, you never get the rhythm back.
Turn the rate down until.
So that's the safest way to do it. You just turn the rate down, and then you can turn it back up. So if you see people, they unplug it, do the pause button, they turn it off, all those things, it's rare, right? Most of the time they find the rhythm back, but there's a chance that you could lose the rhythm. So the safest way to do that is to turn the paced rate down until you see what their rhythm is. Cool. All right, that's all I got. Any questions on pacers?
Can I ask a maybe dumb question? Yeah. If they're AV pacing, you're just like randomly picking which one to reground. Like, I'm confused about why you can just pick either side to manipulate.
Which one do you do? So not that many. So I think it's rarer that our patients are AV paced. Like oftentimes it's like if they're trying to maintain normal sinus rhythm. Mm-hmm. If you have a patient who's asystolic, the critical thing is you need a ventricular beat.
Sure.
So if you try to troubleshoot the atrial side, it's possible that they also have 30-degree block, and so you have the atrial. Now you have P waves, and you have atrial contraction, but you have nothing on the ventricle side. So I wouldn't worry about the atrial side. Just go to the ventricular side.
The reason why if you're just plugging in the ventricular side, sometimes these connectors are reused, or sometimes they're brand new, and one side works better than the other. I didn't put them together. I can't explain it, but that's why we swap polarity, because sometimes it just works, and in these situations you just don't argue when it works. That makes sense. Same thing with grounding. It's the concept of grounding, I think Chris does a great job of explaining, but most of us, I know when I was a fellow, I just knew that was the third thing you did. I didn't really understand how pacers worked. So you guys are way ahead of where I was when I was in your shoes.
Do you, and remember, how do we know which is the ventricular, which is the atrial? What's the convention we said? There you go. Okay. Okay. So you saved this patient. The next door, young patient, 42-year-old patient. They had just came out of the OR. It was 5 hours on bypass. They had a triple valve replacement and CABG times 7. Their STS mortality score was 99%, but it doesn't matter now. They're here for you. You notice when they come out, so initially they're hemodynamically stable, but it seems like they're a little bit juicy.
You want some?
Oh, that's amazing.
Help.
All right, so who's my volunteer for this case? All right, George. So when do you get worried about chest tube output?
In the first hours, about 400, 500 cc?
Yeah, so a lot of like the literature published, there's different protocols, different places, but some of the published numbers would be like 400 in an hour. This is very worrisome, right? Our protocol is what, 50 cc's every 15 minutes for 3 consecutive measurements, kind of saying, okay, it wasn't that something happened, we turned them and there was blood in there and it dumped, and it was just blood that had collected. There's consistent bleeding happen. So, okay, so you're seeing that there's 50 cc's the first 10 minutes, there's 75 cc's the next 10 minutes, and it just keeps going. So what is going through your mind? What are things that you're gonna do to try to slow this down, and what does that mean, slow it down? Like what kind of bleeding are you trying to differentiate between?
Whether it's something that needs to be surgically fixed or something that's a medical bleeding.
Yeah, so very good. So medical bleeding, what does that mean?
So whether it's coagulopathy, whether it's protein reaction, or something that can be fixed medically, whether given medication or just given blood products to kind of temporize the situation until we get it fixed. Or if it's something that it's bleeding from the the anastomosis site, or the graft bed that's bleeding that needs to be fixed.
Yeah, so right. So you're trying to differentiate coagulopathy, which we can fix, or get time for it to fix itself. That doesn't need to go back to the OR, because we take those patients back to the OR, they do worse. Patients who have resternotomy, whether you find something or not, do worse. All right, so what are some things that, you mentioned coagulopathy, right? So this patient's been on bypass, we said, like forever and a lifetime. So being on bypass, you can add to their coagulopathy. Certainly we can look at our typical coagulation factors. Are they cold? Patients were on were hypothermic for many hours. Did they get enough protamine? Did they get too much protamine? So they've been on heparin for the procedure. So kind of built into our protocols here in a lot of places that you may not even kind of pick up on because the nurses will just order it, right? They're going to correct things like their metabolic acidosis, right? So we're like, oh, why are they giving bicarb? That's what they're doing to try to correct that for bleeding purposes. We warm them up right away, right? And then we're checking their labs, obviously correcting any sort of coagulopathies we see. So what else? So let's say the patient's still bleeding. What else can you do to try to slow that down if it is from a coagulopathy, other than correcting any, like giving platelets if platelets are low or fibrinogen low, etc.
You're talking about in general, or?
Yeah, management-wise. You may not know the answer. You can phone a friend.
So, sometimes you can be able to give like TXAs to patients to kind of help slow down the bleeding. Again, I don't know if that's appropriate for this patient or not, but in general for medical bleeding.
Yeah, so a lot of places will have like Amicar or similar things built into their protocol, and they'll give it in the OR. Here, I've talked with their surgeons before giving that.
For our protocol here, and it's built into almost every CT surgical protocol because studies show that giving antifibrinolytics post-op, like in that period between liberation from bypass and coming out to you in the ICU, reduces bleeding. So there'll be aminocaproic acid, and in some ICUs internationally they'll use TXA. Here in the United States, we largely don't use TXA. It's a discussion for another time. But yeah.
Okay. So thinking about other medical adjuncts, right? What other things can you manipulate for the patient? You may not know. You can phone a friend.
To stop bleeding.
Try to be a nerd.
I'm not sure.
Increase their PEEP.
Okay, so to try to decrease that potential space, try to tampen it off, right? So we often go up on their PEEP, the tidal volume, or both. if they're bleeding from a surgical issue, it's not going to work. If it's a medical issue, maybe you'll slow it down a little bit, give a little bit of, pressure on the bleeding source, and then stop over time.
Yeah, I mean, and it'll be surgeon dependent. Some surgeons like tidal volume, and they'll want you to go up on the tidal volume. Some surgeons will like PEEP. Some surgeons will say both, and some surgeons will be anti-PEEP. Again, transmural pressure, there's always a concern for graft patency, but whatever. When a patient's bleeding, they'll do anything they can to not go back to the OR. So have that discussion with your surgeon. Some of them have different preferences for tidal volume versus PEEP. But yeah.
When you say go up on feet, like what are we talking about? Go up
So
to
like-
10, or are you going like 20, or are you
Like
going
10.
40?
Yeah, like physiologic values.
Yeah.
Like one, you'd be like, oh, okay.
Or
A
not just
little bit
like
of PEEP.
shunting. Okay.
So like go up from, you're on 5, go up to 8. And 8, go up to 10. Beyond that, I would be like, all right, it's not fixing the problem.
Take care of me.
In the same line of I guess the same question. Tidal volume, how high are we talking?
Well, you probably notice, if you've been on Blue yet, you probably notice they come out usually on higher tidal volumes than most of our patients would be on. So a lot of them come out on 5, maybe 550 or something. I've had gone up to like 600, 650. Beyond that, again, it's like, what are we achieving here? But in those cases, you're like talking with your surgeon on the phone, like, hey, I'm seeing this output, and based on what you're talking about, what they want to do. Yeah, we're not talking about a liter tidal volume. Okay, so you went up on the PEEP, you went up on the tidal volume, you checked all your coagulation factors, you repleted everything, you warmed them up, you fixed their acidemia, they're still bleeding.
So you're going to go through factor 7.
Okay, good. So factor 7, so it's been described in the cardiac surgery literature. It can help with stopping postoperative bleeding, and Dr. Bowen is one person who tends to like to give it before he's going to take someone back to the OR. It is something I always want to discuss with the surgeon because there are risks of MI, stroke, ischemic events associated with it. It's not minuscule. It's in the several percentage range. All right. So you give factor 7. You talk to the surgeon. They want you to give it. You give factor 7, and still bleeding. Okay. So you get tag. You get Rotem. It shows it's pristine. No coagulopathy is seen. You can unplug it to the number plug.
Start back in the surgeon's.
Okay, so you're talking to your surgeon, right? So you're calling him? Okay. So you call the surgeon, said, I'll try, give some more FFP, give some platelets. Call me back.
Put him down.
All right, so it's still bleeding. So you call them, they're on their way in. I'm gonna come check them out, but I'm 45 minutes away. All right. So bleeding, we should mention this. So what is one thing that the nurses are doing when they come out of the OR? Stripping, right? So stripping the tubes, you don't want them to clot, right? So learn from them, learn how to do it. I know our surgical friends here can do that all the time, and it's very, that's why they keep them patent, because if you're bleeding, the worst thing that can happen is things clot off. So let's say this patient is no longer seen to be bleeding, the chest tube output is minimal, but they're hypotensive, 60s over 40s now.
Okay. So, a few things you worry about, whether they have a temperament, physiology from bleeding into the pericardial space. It's going to be hard to get a TE on this patient because of everything that's going on. So if you can get a bedside TE, very appropriate to do. Also, you can also get a chest X-ray just to make sure they don't have a large effusion.
Okay, so you get a chest X-ray. There's a big, there's a left pleural effusion. Pretty large.
Yeah, then they definitely need to probably go back to the OR.
Okay, surgeon's 30, 45 minutes away.
It's not
60
draining
over
that
40.
side? That's the side that's not
All
draining?
the tubes aren't draining. There's a big left pleural effusion. It's like 2/3 of the chest.
So the tubes are not drained?
Not draining.
Okay, so we'll either try to strip it. If it's not working, then you have to put it in the chest tube.
All right, let's put a chest tube in.
Noel Claudio.
You know they're going back to the OR and let it clot off.
All right, George.
We're doing this?
Yeah, but it's just
You are doing this.
Okay.
You know, they're going back to the OR and let it clot off. The atrium, there's just more space for them to bleed into.
No, he's saying he's going into tamponade.
So one of the things that they often open, they can open they'll open the pericardium into the pleural space. So if you're thinking that this might be tamponade off, that's one thing maybe alleviate that. That's kind of the clinical center we're talking about. But yeah, you're right. Like if you were tamponading off and there was no tamponading off the bleeding, but you didn't have compression on cardiac structures, then you wouldn't want to drain it.
Yeah.
Okay. Well, I can't get this out, so can I just talk through the procedure?
No. That's not
Use your muscles, George.
So I guess, does everybody know where your chest tube tray is?
Yes. In the heart cart.
In the heart cart. So I guess if you guys need a thoracotomy tray, you would request. Does everybody know what the heart cart is? Okay. What is the heart cart? It's a cart made for hearts, right? And where is it?
Behind the other cart.
Behind. So on the blue side, hiding behind the procedure cart is the heart cart. And once you guys watch out for a second, I'm going to bring it in, just show it to you real quick without occupying too much space. While we take a minute to get all of our tools, everyone's familiar with the heart cart. Has a nice stepwise progression of what you may need, right? All the way down. Now you have impella purge cassettes on top. How do you get into it? It's locked.
It really wasn't locked in.
It's locked today. Yeah. So in order to get into it at 2 a.m., you have to know how to get into it at 2 a.m.
Kick it really hard.
Is there a key box somewhere?
Oh, there's a key back here.
Oh, there's a box. There's a metallic box.
Oh, you test perfusions?
There should be one of the little
Perfusion's at home sleeping. There's no ECMO patients.
Oh,
Yeah. So there's a locking code on the back. So what's the code?
4829?
Nope.
It's like two.
None of you guys know?
No,
You never
it's
used it. All right.
It's always open.
All second years are now been devoted to first years.
Right.
One more year of training. It's cabbage.
Oh, that's unsatisfying.
There's alphabet.
No, you have to figure that part out for yourself. Right?
3, 1,
So
2,
you need
4.
to see it.
3, 1, 2, 3.
How do I do cabbage 3 in the morning?
Your phone now, look at that.
Wait, really?
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 You want to try?
Oh wait, is it keypad or
Two keypads, so it's like
Coming back in. I thought this would only take a second. So
2,
you gotta get your
2,
phone.
2, 4. 2, 2, 2, 4.
Who wants to unlock the card? So do it
Yes, I
then.
said a bunch of
It
twos.
better be 2, 2, 3, 4.
Get locked.
Nope.
Oh, there.
Oh, so press clear first.
2, 2, 2. Okay.
Alright,
I'm gonna leave it unlocked.
You can put a sticker on it.
Why is there a lock on it?
Do you need it or you have everything?
anything emergencies.
Chris,
Oh,
you need it?
we got everything we want.
Fail safe key or something.
Alright, so I guess we're putting the surgical chest tube.
Alright, they gave George time to get warmed up.
Alright, surgical chest tube. So basically, we're going to go to the mid-axillary line around intercostal 4 space. Make a
Your 4th, 5th intercostal space. So think of your triangle of safety, right? Yeah. So where the lat comes down, the pec comes down, your axilla in that area. So arm up.
Yeah. And if the patient is awake, you know, kind of numb pretty good all the way down to the pleural space. So we make an incision about 1 to 2 centimeters, enough to get the finger in. And once I feel lung, kind of make sure that it's not attached to the chest wall, go around. And then, after dissecting, before I can do that, so make the skin incision, use the blunt Kelly to kind of blunt dissection all the way down on top of the rib and not below the rib above. So that I don't injure any intercostal vessels. Once I get into the pleural space, like I said, make sure that the lung is not attached. And then once I'm able to attach the tube to the Kelly and then get it in there, after draining. Yeah, so if you're draining, this is blood, so I'll usually try to aim it more inferior posterior, where usually it's going to accumulate, and then suture it in, and then hook it up to go back.
Awesome. All right, put it in.
Oh.
You may want to clamp the end so you don't get blood all over your feet.
Yeah,
Let it go.
that's the beauty of sim lab. Everybody leaves messy.
Alright, so
Once you pop in, spread, come out, finger in. You go this way. Put over. And then guide with your finger. So if you don't have a big enough incision, just make it bigger. Once you're in this space, then you're going to come off with your Kelly, and then just feed it in. Yeah. So most patients, right, go into 10, 12, they'll go more than that unless they're obese, because you risk going into the mediastinum or other places.
okay.
All right, cool. All right. So we're going to connect it. So how are you going to connect it? So you got.
So, well, you can set up a little different pleural bag for it, or if you want to.
Yeah, so we have one. I think you put it in there. Is it on that card?
I think it's over there.
So you always want to cut this thing off so the connection, right? So this doesn't actually connect. You're going to cut this off and connect it there. Okay.
There's one here. Sandra, there's one here.
Oh, great. Thanks.
All right, good job, George. Okay, so some blood comes out. All right, some blood comes out, and then no blood comes out again. The patient's becoming more hypertensive. 30s, now 30s over 20s. Now they go into VFib.
VFib, so shock.
Okay.
I got this question wrong this week.
Okay.
3 times. And then, so we'll shock.
Okay. Yeah. So what you were pointing out was on the guidelines for cardiac surgery patients for cardiac arrest are slightly different. If someone goes into VFib, the first move is to shock up to 3 times within 1 minute before starting CPR. And the other thing we pointed out is if they're in asystole, pace them or try to get them paced within that 1 minute period before starting CPR. Now we're talking 1 minute, right? So this isn't like you delay our normal CPR external chest compressions longer than that. But if you have everything ready and you're doing that shock, 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 you may get them back. Now this clinical scenario, probably not going to get them back. They're bleeding or tamponade, right? But those are the 2 differences there. If they're in PEA, start CPR. Okay? All right, so you shock 3 times. They're now in, it looks like sinus on the monitor, and their blood pressure's 30 over 10, undetectable.
And no pulse?
No pulse.
Considering PEA. So, I guess we start chest compressions, CPR.
Okay.
And, we'll probably have to open the chest.
Yeah, so open the chest, right? So this is the patient that we need to open the chest. It's indicated really up to potentially 10 days. Obviously, we're in discussion with our surgical colleagues about, what, this is someone, if they were going into arrest, obviously we're talking with them beforehand, getting them on the phone as we prepare to open the chest. Okay? They good to go, we're going to open the chest. All right? And obviously we're calling, we have a lot of resources in this hospital, so calling trauma overhead, come to the bedside to help with that. We had a case a year ago, 2 years ago, up on P10. Same thing happened. But yeah, we're gonna open the chest. All right. So George, you can get an assistant, and you're gonna open the chest.
Pick anybody.
Sure.
Alright, whoever wants to do it.
Come on. When was the last time you opened somebody's chest? Come on, Deb.
Okay, so you guys are getting gowned and gloved. All right.
Okay.
Okay, so the way this should go down, right, is you guys are getting ready. If you're the qualified person to open the chest, and this may be the case, so Cooper, we have a lot of resources, but other places you may be the most qualified person to do this. And certainly, if someone is busy in the OR or whatever, this has to be done. The patient's dead. Opening the chest is indicated. So somebody else is going to be doing CPR, right? So they're doing CPR. Often we'll say you may, when you're disrupting the sternum, right, there's wires right under here. So one thing that we often do is grab like a lunch tray or something to try to protect the person doing CPR. So they're doing CPR. As they're doing CPR, you guys are getting sterile, getting anything prepped to then pause CPR, drape, resume CPR as someone's sterile, doing CPR, and then opening the chest up. Okay? So that's happening.
And move quick. I mean, you're talking about drape, take a bottle of betadine, just shoot it on the chest and move on.
Okay. So I guess get the scalpel, make an incision within the chest. Well, I'm in the wrong position. You're gonna have to do it. Put it on that side.
You're going to cut down on the incision, so on the midline sternotomy incision, you're going to cut down to the sternum. And be careful with them. There are wires there. They're from fabric stores.
And then use the wire cutters.
Yep.
Just pull them up to you. So you see how they're pointed down flat?
So we have somebody else with the hemostat. Needle. Driver. If you want to pull them up, then let him snip, and then you're going to pull them away.
So point towards the ceiling and then cut them.
Kind of a question for the attendees. If you've been in this situation, what was the most unanticipated thing that happened during this in an emergency situation that you didn't know before?
Incontinence.
That part too.
No, I'm gonna leave that one. Generally speaking, it's pretty easy to get in the chest. It's just having everything in front of you and then the willpower to proceed, right? And knowing that this is a time-dependent intervention and it's indicated. If you're a medical person like me who spent their lives dealing with molecules, getting over that initial inertia to open the chest, I think but also, having an understanding about what's going on. Again, where do you think the hole is? If you do open the chest, can you fix the hole? Right? So one thing is medical bleeding from an anastomosis, or I should say surgical bleeding from an anastomosis site where you have a vein graft that's oozing, developing tamponade is different than if you have breakdown at the aortic cannulation site, and you have, so when you open the chest, you alleviate tamponade in one patient, or you shoot blood and touch the ceiling in the other patient, you better have somebody around you that can plug that hole. So having while you work through it, talking through the scenario, and having your surgeon, about where do you think the bleeding is coming from. Like we said, we're always worried about bleeding from the graft takedown site from the left chest, right? It doesn't affect the mediastinum, doesn't affect tamponade. Bleeding from the surgical anastomosis is probably the more common place to bleed from. Now again, pericardium is open, there's connection with the left chest more often than not. That's why those tamponades tend to show up late, they tend to be loculated, right? You can have bleeding from the aortic cannulation site. You can have bleeding from the cold cardioplegia cannula. Did I touch them all? I think that's most. And then the cross clamp site. But aortic stuff, I got trauma with me, right? Everything else, you can probably pop open, alleviate a little bit of pressure without fully opening the heart, and probably still be okay.
Yeah, if this is really just tamponade, just opening that sternum, maybe just doing that alleviates it, and then you have a perfusing rhythm back.
Yeah, you pop a couple wires and stick a Yankower in, suck a little bit out. That's enough to alleviate the pressure oftentimes to reestablish a rhythm, and then they're whisking the patient off to the OR. You don't have to necessarily open it up completely, but for SimLab purposes, you must see the heart.
Okay, so we open the heart, looks like there's tamponade and blood clots around the heart.
Okay.
So we just suction and see if we can get anything out.
Yeah, so essentially you're just going to have your sterile suction, so you're suctioning out, right? See if you can alleviate the tamponade.
Yeah.
Huh?
Is there in there?
Yeah.
Last year.
So, and if suction doesn't do it, use the next best thing.
Hand?
Yeah, so you're grabbing the clots out.
Stick them in the black bucket for us.
Oh, be careful, there's wires right there. Let me get you another bucket.
Well, whatever.
Very close.
Here's the Jello bucket.
Scoop it out. Hurry up, patient's dead.
Have to open it a little bit more if we can.
Open it up, George. Give us some space.
I wasn't sure how.
Give us some space to work.
There we go. Now I can do it.
Alright. That's better.
So what rhythm are we in? So we,
You can see the heart beating.
oh, it's beating?
Yeah.
Okay.
Gotta move it around. Alright, that's most of it.
Yeah. Alright, so now the patient goes into VFib.
VFib, so we'll shock again, but this time, since it's open chest, we use internal paddles.
Internal paddles, yeah. And how much are you going to shock at?
30.
So yeah, pretty close, like 20.
20?
Or 20.
Okay.
And where are they located?
Heart.
In the heart cart. And what is the combination?
Cabbage.
Yeah.
Alright, so you shock them out. It looks like the heart is in some sort of rhythm, but there's no detectable blood pressure still.
Okay, and no palpable. The heart is not beating?
Heart's like making some movements, but there's
Wiggling.
blood pressure.
Not beating.
We'll start, just internal massage.
Okay. Do it.
She's already been in there.
You can take the heart out if you want. It's detachable, and just demonstrate for the group how you would massage the heart.
Okay. So flat hands. Okay. Use the base to your palms, kind of the apex, and so you're gonna apex to base. Okay. Other way.
There you go. Like that.
So you have to be on the left side.
I mean, you have the heart in your hand, so.
Here we go.
Yeah. So kind of like this. So don't put your fingers through the atrium.
Soccer, will you do that?
Okay, patient wakes up.
Don't show him the heart.
All right. Very good. You saved the patient. So, So we talked about a couple things, right? We talked about medical versus surgical bleeding, right? Correct our coagulopathies. We can do things to try to increase the intrathoracic pressure, go up on our PEEP, go up on our tidal volume to try to decrease that potential space, increase the pressure. There is some sort of just kind of oozing, maybe that will tampen it all off. We corrected our coagulopathies. We considered the factor 7 in discussion with our surgeon. We recognized when that wasn't the case and there was ongoing bleeding, right? We resuscitated, but even with that, we called our surgeon in because they needed to go back for re-sternotomy and re-exploration. And then, unfortunately, the patient tamponaded off his drains and therefore bled into his chest. And remember, these the pleural space may be contiguous and often is contiguous with the pericardial space because they've accessed pleural and pericardium, right? So you may see a left pleural, a left hemothorax, and relieving that, if that's your concern for tamponade, it may buy you some time. And so that's what we did. And then, unfortunately, a patient arrested and we opened the chest. So we talked about the algorithm for cardiac arrest. And so the difference is with post-cardiotomy patients within the first 10 days. Asystole, we're going to try to pace them within 1 minute. If that fails or exceeds 1 minute, we're starting CPR. If they go into BFib, we're going to try to shock them up to 3 times within 1 minute. If that fails or exceeds 1 minute, we're going to start CPR. If they are in PEA, we're going to start CPR immediately. And all those things are as a bridge to re-sternotomy. Because even though you might say, well, it's an arrhythmia, why would I open the chest? That may actually be due to bleeding and tamponade and other things. Cool. And then if you do find yourself in a situation of opening the chest, just opening it, relieving that pressure, maybe suctioning, evacuating some clot, and holding pressure if you see the area bleeding, probably the extent of what most of us would feel comfortable and do. That is something that we can do if we find ourselves in that situation. All right, cool. Thanks.
Any other questions or scenarios some of the seniors have gotten into?
The internal panels, like anterior, posterior, does it matter? Like on the heart area?
I don't think it matters that much. Trauma colleagues, you guys have anything?
Both sides, just like you know how you do what leads here and here, just somewhat approximate that. Because it's the same vector.
I have a quick question about when you're checking somebody's underlying rhythm post cabbage. So when you're turning down the rate, let's say the baseline rhythm is 360. So how do you go all the way down to 0 and find out you're in the system? or you get to like 30 or 40 and you're like, okay, I don't see anything, I'm going back up.
That's a great question. First off, George, that's a great question.
What would you do?
I'm not going down to 0.
I like your style.
I don't want to find out, so probably get down to like maybe 40 if you don't see anything, go back up.
I think you've proven that they're pacer dependent. That's all you really want to know, right? Yeah, that would be interesting.
Are you giving epi during these codes? Or are you talking that over
Man, that's also a great question. I mean, you're going to go off of that ACLS algorithm, but you're not banging an epi like you do on the floor. I mean, obviously, afterload's an issue. Sometimes when you get ROSC, they have blood pressures that are very difficult to control. You're back on nitro. I don't know. I mean, usually it's again, these are reversible causes. You're trying to buy time, maintain perfusion, and reverse what's underlying. It's very different than than an out of hospital cardiac arrest who rolls into the ED bay or somebody who arrests on K9.
Yeah, and if you look at the guidelines, like they say, kind of consider epinephrine at the advice of a senior person. So I think if you think it's something that's going to buy you time to get the person back, then it's reasonable to consider, but it's not like arrest epi,
Yeah, it's not like your PA arrest where you're just slamming it. I mean, a lot of times you have multiple drips hanging, so the nurses are just going to turn everything on, and you're going to know whether or not they're epi responsive. You know what I mean? So.
You guys been at the bedside for any of these?
Yeah, Saturday.
Saturday?
Yeah, we had a bleeding patient, had to go back to the OR. We had gone up on PEEP, we sedated her, we got you factor 7, she was just pouring out. She ended up putting out like 415 minutes at one point.
Wow.
So it was just stripping tubes and transfusing and getting her to the OR.
And I'm not gonna lie, like of all, prevention, is the best intervention, right? So, you guys all should know how to strip chest tubes. And I mean, so if you don't know how to strip a chest tube effectively, because it is a skill, number one, don't pull it out. Number two, actually create enough negative suction to strip a chest tube with clot. Because again, these patients are, when they don't have medical causes of bleeding, they're going to develop clot in their tube, right? Adisa will teach, she's the one who taught me how to strip a tube. She'll teach you how to strip a tube. We have a lot of new heart nurses. And, as you sort of onboard new people, I think a lot of us take for granted there's people in there that, live their lives stripping tubes. When I was a fellow, nurses it was like a never-ending process of tube stripping. And again, sometimes you won't know where they're bleeding from, different attendings use different connectors, it's not always, you don't always know which one are the mediastinal drains and which one are the pleural drains, depending on the surgeon. Many of us will know because we're used to what they're used. You guys might not have any clue which pleural drain could be coming off of the right side. Everything could be crisscrossed inside. So, the point here is you really need to be able to strip tubes. And every once in a while, you can find yourself and one of them clots off. You can troubleshoot, and that's like, that's at the surgeon's discretion. Sometimes you can, sterilely stick a suction catheter up a mediastinal drain and try to pull clot, if you're really worried. But those are all things that, again, you want to communicate in real time output and when output stops. And, factor 7 can slam the brakes on everything. I tell you that right now. Yeah. So, be ready. That's all. Think through it. Be confident and communicate. And that means knowing your output, every 15 minutes, what is the trend? Being ready to, approach Dr. Rosenblum at 10:29 on a Saturday with exactly what you need in order to advocate for him to come in, and not get pushed into a different narrative. But communication is key.
They'll be annoyed if you call too much. They'll be livid if you don't call enough.
Yeah. You can never be wrong for calling. It's just, knowing what information to relay. They probably don't want to know, when they have their last colonoscopy. Don't start the conversation that way.
I think having in your mind what do you think is going on is really helpful for them. I think they want to know what you think if you're at the bedside. So offering that like we would any other patient, obviously.
And commit. Be like, I think this person's bleeding. And they'll say, you're stupid. You say, okay, that's right. But commit. Because it's easy to get to backpedal and try to work through your differential, and it becomes like word soup over the phone. So just commit to what's going on, give them the trends, and and use some of that clinical gestalt. This person looks bad, right? This person looks okay. Because a lot of times that's all you have to work with.
Cool. Thanks, guys.
Thank you.
Thank you.
Any